Hi, welcome to our discussion about pneumonia and the different documentation opportunities that are going to be identified to help us all identify the risk of severity, the risk of mortality, and also the severity of illness of the patient populations that we're taking care of. As we know, patients are coming into the hospital sicker and sicker, and we are needing more resources to take care of them more efficiently and more effectively so that they have better outcomes. So really we need to incorporate the aspects of the provider documentation that really speak to the assignment of all the diagnosis codes and the procedure codes that are needed on a patient count to be identified that determine the primary working diagnosis and diagnosis related grouping assignment with that unique relative weight, RW, you'll see that speaks to the intensity of resources needed to adequately take care of this patient and provide them with the best outcomes. Thank you. So this is just the standard disclaimer statement I have on every discussion. That every effort has been taken by the author of this presentation to ensure that the information has been shared was as current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share it in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is only intended as just that, to be informational, and is not to take precedence over any state, local, federal guidelines, organizational policies, or procedures. So once again, we are going to review some documentation opportunities that really speak to the intensity of resources, the severity of illness, the risk of mortality, all the conditions that are being treated, evaluated, worked up for that really affect the assignment of the primary working diagnoses and the DRG assignment, diagnosed related grouping assignment that has the relative weight that speaks to the intensity of resources required to take care of this patient. So, for instance, some providers continue to document using the non-specific terms such as opacities are bilateral or a new infiltrate to document the diagnosis of pneumonia. Well, opacities bilateral, new infiltrate do not translate to a code. So be specific and document the type of pneumonia. Coders are unable to use the documentation of conditions that are noted in reports, the ancillary reports, such as a pneumonia finding on a chest x-ray or an organism that's identified in a path report. The attending provider needs to have that in their documentation reflected in the provider documentation in order for the coder to assign a code. And again, the greatest specificity allows for the greatest specificity of documentation, provides the coder with the basis to code to the highest specificity that leads to a higher diagnosis-related grouping assignment. Again, this does not affect the care that the patient gets, but however, the greatest specificity that's provided in the attending provider's notes adds to a greater continuity of care because that doctor has, that provider, nurse practitioner or PA, has documented a more accurate picture that is as specific as possible to give a more accurate picture for the provider following them the next shift, the next couple of days. So they're able to see a true and accurate assessment that allows them to compare if there's been any differences. And it also adds to the medical necessity. So the more specificity that's in your documentation, the better. So always remember the specific disease-causing agent or organism responsible for the condition of the patient must be documented in the attending provider's notes. If the consulting provider documentation reflects something such as pneumococcal pneumonia and the attending provider's notes documentation documentation does not reflect that condition, then the attending provider will be queried. As we all know, medicine is not definitive. It's not absolute. Sometimes you're working up a diagnosis and it's maybe possible pneumonia or probable sepsis due to pneumonia or suspected. So the process of working up these patients takes resources for evaluation, testing, monitoring. So take credit for the work you've done. Therefore, document when appropriate that the condition is possible or probable or suspected. Please document on the pneumonia throughout the hospital stay. Also, please note whether it is stabilized or resolved. For instance, if the patient has signs and symptoms of severe sepsis or septic shock due to the pneumonia, then please document that. Capture the accurate picture of how sick this patient is. If the documentation of pneumonia can be linked to the sepsis, severe sepsis or septic shock, or any other related condition, then it must be linked in your documentation with the statement such as sepsis due to pneumonia or sepsis due to whatever other, like post-implant complication. So use verbiage that speaks to the cause and effect relationship, such as secondary to, due to, or other similar language, like again, as I stated, sepsis due to pneumonia, because your resource intensity for taking care of somebody with pneumonia versus sepsis due to pneumonia is quite different. There is a higher use of resources and intensity of care that is required for taking care of a patient that has sepsis, severe sepsis, or septic shock due to pneumonia versus somebody who comes in with simple pneumonia. So please be mindful of that. Pneumonia is classified coding as either simple or complex. Ensure that your documentation is as specific as possible to capture the severity of illness and risk of mortality that is accurate reflection of the intensity of resources used to care for the patient. The below terms are some examples of those conditions of pneumonia that are classified as simple pneumonia, such as atypical pneumonia, community-acquired pneumonia, healthcare acquired pneumonia, viral, pneumococcal pneumonia, influenza. So all of these are simple pneumonia with a lower intensity of resources required to take care of them versus some of the terms are used to examples to classify complex pneumonia, such as ventilator-associated pneumonia, aspiration pneumonia, gram-positive pneumonia. These require a greater intensity of resources, and so the documentation of this in the attending provider's notes reflects that and therefore allows coding to be of the highest specificity. Once again, that documentation of the cause and effect is essential because that is critical for a proper code assignment that reflects the intensity of care, the resources used to care for this patient. Also, it is important and critical to document the provider thought process in terms of monitoring and treatment plan. This will also help to justify the medical necessity of keeping a patient in an inpatient bed status in the acute care hospital. This is essential and critical for getting payment. If we cannot establish medical necessity for this patient being in an inpatient status in an acute care facility, then we do not get payment. This once again wraps back around to us not being able to have the monies needed in order to keep the doors of the hospital open. And not only just keep the doors of the hospital open, but also to provide and build service lines and other procedures and areas of the hospital that can take care of patients. So let's just take, for example, this patient, a 90-year-old that came in with probable emesis after eating their lunch, dehydration, their electrolyte levels were off. And so a clarifying query was sent to the attending provider that provided the below results. We were able to increase the specificity of the attending provider documentation of a patient with pneumonia to that of probable aspiration pneumonia, and also increase the specificity from abnormal lights to that of hypernatremia. The result of that was more than double the relative weight assignment and a more accurate reflection of the risk of mortality and severity of illness of this patient. Somebody who comes in with probable emesis after their lunch develops pneumonia, and we're able to further clarify that to probable aspiration pneumonia. Also increasing the specificity of the abnormal lights with the increased sodium levels to that of hypernatremia. So that really paints the picture of probable aspiration pneumonia, hypernatremia, that more than double the relative weight and presents a more accurate picture and reflection of the risk of mortality and severity of illness. This really tells the story and paints the picture of how sick the patient is. And remember, any condition that you're monitoring, treating, or working up for the patient are necessary to include in the attending provider documentation. This allows the coder to add these diagnoses to the patient count and more accurately capture the complexity of the patient. This is just an example of a slide I've used in a previous presentation where once again we speak to where the consulting provider had documented that the patient had sepsis, but the attending provider did not have sepsis in their documentation. So the CDI professional or the coder sent a query to the attending provider, and the attending provider confirmed that they had a sepsis diagnosis. So therefore, we were able to change the medical severity diagnosis related grouping 178 with the reimbursement of approximately $13,000 to that of group 871 that is a more accurate reflection of the intensity of resources, the severity of illness, and the risk of mortality for this patient that had a bigger reimbursement of $20,000 approximately. So this is $6,766.15 for this patient account. Now think about that. If you have 5 of these on a unit, on a med-surg unit, that's a conservative amount. But so that's almost $35,000 difference. That would be in addition to what you would have received otherwise. So let's just think about that. So once again, this wraps around to us really documenting the accurate picture that leads to the to the highest specificity of code assignment that leads to the more accurate reimbursement. No money, no mission, and if we win a place to carry out the mission of caring for our patients, then we need to work as a team. Here's some references that I'm happy to share that were a great asset in putting together this presentation, so thank you. This is the second page of references that I also use. I hope you find them helpful. Once again, I want to thank you for participating and listening, and I hopefully will share this information amongst you all and your colleagues so that we can all learn and we can all grow because we all want to take care of the patients that are in need of our care. So thank you once again, and I really appreciate you participating in this video presentation. Have a great day.